Mantle cell lymphoma is a relatively rare subtype of B-cell non-Hodgkin lymphoma. It generally occurs in older patients and has a male predominance, about 2/3 to 3/4 of diagnoses. It's characterized in most cases by a cyclin D1 translocation, and that's about 95% of cases that we identify. The usual paradigm of indolent and aggressive lymphomas in B-cell doesn't totally fit with mantle cell lymphoma. There's definitely patients who present with a more aggressive presentation, but we do have fortunate patients who have a more indolent presentation and are potentially candidates for surveillance when diagnosed. Mantle cell lymphoma can present in a variety of ways. In my practice, I have a number of patients who it was diagnosed incidentally, meaning they're totally asymptomatic. So maybe it was picked up on a routine mammography, routine colonoscopies, given that it can occur in the GI tract. So on one end of the spectrum are patients who are entirely asymptomatic. The other end of the spectrum are patients who unfortunately do have disease-related symptoms. Those can be variable. It can be typical B symptoms, what we call, which is fevers, night sweats, unexplained weight loss, loss of energy, appetite. There can be local symptoms from tumors growing. So if the spleen is enlarged, that can press on the stomach and cause loss of appetite or abdominal discomfort. If there's enlarged lymph nodes, those can be felt by the patient themselves, for example, in the neck or the groin, where it's closer to the skin. And then if there's other tumor growths that are near organs or other parts of the body, patients can feel those effects as well. But it is variable from patient to patient, whether they will or won't have symptoms. And then finally, if the patient has low blood counts, that can also contribute to fatigue, lack of energy, and such. The ways that patients reach us are variable, meaning, again, asymptomatic on one end of the spectrum or highly symptomatic on the other end of the spectrum. The core tools that we use to diagnose lymphoma apply to mantle cell lymphoma. So there's a clinical history that leads to imaging or other studies that eventually lead to a pathologic diagnosis, and that can be a bone marrow biopsy or a lymph node biopsy most typically. So that's definitely one of the core features of diagnosing mantle cell lymphoma. The other thing that goes along with that is typically a PET scan for full staging head to toe to see any metabolic activity that would indicate lymphoma in different parts of the body. And those two things together really form the complete picture. Beyond just the morphology and the immunohistochemistry and flow cytometry on the lymph node biopsy or other site biopsy, we're relying more and more on molecular tools to help, number one, confirm the diagnosis if there's any uncertainty which can occur, or number two, help to maybe risk stratify patients and choose or de-choose therapies in the future. One of the main features that we use at MSK and at other centers in the US and around the world is a protein called p53. What we've observed over time is that patients where their tumor has an abnormal p53 protein, that can influence the outcomes, where if it's abnormal, it can be a little bit more of an aggressive disease presentation, and the outcomes historically have not been as good in that situation. And so for all patients who are newly diagnosed, we typically would assess the status of p53 protein through testing for a mutation in the TP53 gene that encodes for that protein. So we do that at diagnosis, and we consider that to be a fairly essential part of diagnosing mantle cell lymphoma and understanding it better. And finally, besides confirming the diagnosis, there are other features on the tumor that help us understand how it may behave in the future. The frontline treatment for mantle cell lymphoma is evolving a lot in the last couple of years in promising ways. In our practice and within our group, and a lot of other centers mirror this, it depends on a number of different factors. Number one, we do take into account the status of that p53 protein, TP53 gene, the age of the patient, whether they have comorbidities or not. All of those factor in, and of course the patient's goals and preferences for therapy. The main determinants are the age and comorbidities and the p53 status. For younger patients who don't have a lot of comorbidities, who are relatively well off, we typically talk about intensive therapy with something called the triangle regimen that was developed in Europe. And that's a combination of chemotherapy, immunotherapy, and targeted therapy all together. And the total duration is about 3.5 years for most patients. So that's one option, and that's when TP53 is not mutated. Across different age ranges for patients where the mantle cell lymphoma harbors a TP53 mutation, we typically use something called the bovine regimen that was developed at our center in partnership with other centers in the United States. That's a chemotherapy-free approach, specifically targeting patients with that TP53 mutation in their lymphoma. And that's building off of historical data that show that the outcomes for patients with that aberration in their lymphoma, given chemotherapy, aren't as good. And therefore, this is a chemotherapy-free approach that we've helped to develop. And that's typically what we use for patients who have that subtype of mantle cell lymphoma. For older patients who have a normal P53 gene in their lymphoma and are not candidates for that intensive approach that I mentioned, typically for our frontline therapy, we're thinking about either chemoimmunotherapy with bendamustine rituximab or a combination of targeted therapy and rituximab. So that would be usually acalabrutinib plus rituximab in a chemotherapy-free approach. So it's basically 4 treatment options by and large for most patients. There are rare patients who have localized mantle cell lymphoma where we can use a localized approach, typically radiation, to address that. And in those cases, we've had patients who have a long treatment-free interval after that until they ultimately may need systemic therapy. But it is worth mentioning that there are rare patients who have localized presentations where we can do radiation up front and potentially forestall systemic therapy. For patients who have relapsed and refractory mantle cell lymphoma, the first point is that that's highly heterogeneous. So within that same bucket category, that can run the gamut from, let's say, patients who have a very long benefit to frontline therapy, 5+ years, and are now relapsing, needing therapy. And then at the other end of the spectrum, more concerning would be patients who had no response, or the disease rather had no response to the upfront therapy. And that spectrum does create a clinical challenge for us for how do we risk stratify patients and understand the trajectory and the big picture for where the disease may be heading. We try to match our strategies to that disease trajectory. So it's a favorable trajectory, maybe we would treat it less aggressively. If it's a more concerning trajectory based on the disease features and how it's responded to therapy before, we would typically try to match that as well. So for patients these days who are getting a lot of frontline BTK inhibitors, if they previously responded to that, we would probably re-challenge with a BTK inhibitor again in the future. If a patient has not been previously exposed to a BTK inhibitor, we would typically try that as well. For patients who either didn't respond previously to a BTK inhibitor or who had a very short duration of benefit, we would typically think about an alternate approach, typically incorporating medicines that they haven't seen before. So if they got chemotherapy before, thinking about non-chemotherapy approaches or different chemotherapy than they got before. So for example, pirtobrutinib is an established non-chemotherapy approach for patients who are BTKI exposed, but chemotherapy is also a valid option for patients who are BTKI exposed previously. So chemotherapy, targeted therapy like pirtobrutinib, or a covalent BTK inhibitor if that hasn't been tried or they benefited before. There are data for lenalidomide rituximab that's also a strong option, and venetoclax in combination with rituximab is also an established option in that setting. CAR T-cell therapy is showing a lot of promise in treating relapsed and refractory mantle cell lymphoma. In the United States, we have brexicadogene and lysicadogene that we have in our arsenal. And a lot of patients these days, when they have relapsed and refractory disease, we are moving towards CAR T therapy as a consolidation strategy, especially if there's concerning disease features present. Allotransplant has been used historically and is still in the tool belt as well. That's typically reserved for younger patients who have more challenging disease features, but it is in the tool belt of things that we would discuss. And then there are emerging data for the use of bispecific antibodies as well. They're now investigational, but we're hoping that in the future, if the studies pan out, that they could be another tool in the tool belt to help care for patients. This gets into the heterogeneity of mantle cell lymphoma that I mentioned earlier. In a given day, you can see patients with different disease presentations, and it is highly variable from patient to patient. We know, based on historical data and in our practice, we see patients about 20% when they're diagnosed with mantle cell lymphoma, the presentation is such that they are candidates for observation or surveillance. There's a couple phenotypes or patterns of patients. The first is those patients will have GI tract limited disease, often identified incidentally on colonoscopy. Those patients are often candidates for observation. The next pattern is non-nodal leukemic mantle cell lymphoma, where it's present in the bone marrow and the spleen, circulating in the blood. Those patients can also have a long treatment-free observation period at first diagnosis. And then the last category is patients who have nodal disease in the typical pattern, but the burden of disease and the tempo of disease does not mandate therapy at diagnosis. And those patients can also be observed safely, but they tend to have a slightly shorter observation interval from diagnosis to treatment initiation. So those are the patterns of more indolent presentations. The aggressive presentations, those would be things like blastoid mantle cell lymphoma or pleomorphic mantle cell lymphoma. Those come on more rapidly. Those tend to cause symptoms more readily than the other subtypes, and patients can really be quite affected by it when it first comes on, and they're often in the hospital with major issues. And that's more of an urgency to start therapy in that case. Some of the heterogeneity, again, is from patient to patient, but often within the patient there can be heterogeneity, and we do see over time some patients have an acceleration or a transformation of their disease where maybe initially that has certain features that are more favorable, but over time, with or without therapy, there can be more concerning features that are present. So we know that P53 mutations are typically present at diagnosis, but if that were to be acquired, that can come along with more aggressive or concerning disease features over time. So the variability is from patient to patient, but also over time in the given patient.